We have Matthew Chia, who's going to discuss the second trial. Thank you, Matthew.
Thanks, Dr. Shames, and thank you to the APDVS for giving us the opportunity to present here. I'm really excited today to be presenting some preliminary results from the vascular surgery extension to the second trial. Again, my name's Matt Chia. I'm one of the integrated residents at Northwestern, my 5th of 7 years here. And I've been working together with a number of folks, including Dr. Mal Sheehan and Dr. Don Coleman on this work. These are our disclosures. Practicing vascular surgeons have been demonstrated to be predisposed to burnout and depression, even when compared to other surgical subspecialties. Recognizing this, the SVS recently created the Wellness Task Force to tackle burnout in vascular surgery. Research from that group found age, work-related physical pain, and work-home conflict to be strongly associated with burnout in a survey of the SVS membership. And recent work from the APDVS Issues Committee identified that vascular trainees perceive burnout to be one of the primary threats to the specialty. Based on these and other insights, the second trial was started in 2019 to tackle burnout on a national scale. It is a cluster randomized trial at over 200 general surgery residencies with broad support from stakeholders in surgical education. For the Twitter enthusiasts in the group, this is how the second trial was first expanded to include vascular surgery trainees. Without a doubt, the response to Dr. Coleman's question was an enthusiastic yes. These are the overall aims of the vascular extension to the second trial. Based on the initial data that we obtained from last year's VSite, I will just be focusing today on this first aim. Specifically, with our initial work, we hope to identify some of the hazards faced by trainees in vascular surgery, to understand the makeup of the vascular surgery training cohort, and also to leverage this opportunity to compare wellness between some of the vascular surgery training paradigms. Our data comes from an optional, confidential survey that was ministered after the 2020 VSite. We have excluded any trainees who are on protected research time, taking a leave from training, or who are otherwise not engaged in a clinically active year. Demographic data were obtained from the VSB data, as well as some additional items on our survey instrument. We measured wellness on an abbreviated Maslach burnout inventory, as well as asked trainees about their thoughts of attrition, thoughts of leaving vascular surgery, or thoughts of suicide. We also assessed various factors of the learning environment. Our analyses were conducted with standard bivariate methods and cluster-adjusted multivariable logistic regression. First, I'll present to you data from the full cohort of the trainees. A total of 475 trainees completed the survey for an 84.2% response rate. These were evenly split between the integrated and traditional paradigms, with very few trainees in the early specialization program. Although there is a trend of increasing representation of women in vascular surgery, the current makeup of the training cohort remains 2/3 male. Many integrated programs have now matured to the point of having a full complement of residents, which was reflected across the distribution of PGY levels. 55% of the cohort identified as white, with a further 24% identifying as Asian. Fewer than 5% of the cohort each identified as Black or Hispanic Latinx. Most trainees were at institutions that were identified as academic. There may have been lower proportions of female trainees at community-based training programs, but this was not statistically significant in this cohort. Vascular trainees report an overall 44.6% prevalence of symptoms of burnout on a weekly basis or more frequently. The rate of burnout was similar between male and female trainees. The rates of other wellness outcomes were lower, including 10% of trainees reporting thoughts of attrition, 8.4% reporting thoughts of leaving vascular surgery, and 4.9% rates of suicidal thoughts. Differences in these outcomes by gender are seen in the figure here, but note none of these were statistically significant. We also asked trainees about 5 experiences of mistreatment, specifically gender discrimination, racial discrimination, discrimination because of anticipated pregnancy or childcare needs, bullying, including verbal and emotional abuse, and sexual harassment. As seen here, all of these behaviors were reported more by female trainees than their male counterparts. Female trainees also report more frequent mistreatment than their male colleagues, with 24% reporting experiences of mistreatment at least a few times per year, and almost half of female trainees reporting experience of mistreatment monthly or more frequently. We also found female trainees to report significantly more months in violation of duty hour restrictions than their male colleagues. On multivariable analysis, we found that female trainees were at significantly lower odds of reporting burnout compared to their male counterparts. Consistent with previous work, we also found that reporting mistreatment monthly or more frequently was associated with a 3 times higher odds of burnout, and increasing months in violation of duty hour policies were also associated with higher odds of trainee burnout. There were no significant differences observed by PGY level, program type, or program geography. We found that program level rates of all of the studied factors were significantly variable, including program level rates of mistreatment, duty hour violations, and burnout. Although the variance at the program level is likely increased by the small size of vascular training programs, it is still clear that trainees at different programs are likely to have very different experiences. Finally, I want to present these data from a subgroup analysis to compare these same factors between integrated residents in their final 2 years of training and traditional fellows, as in many situations, these 2 levels of training can be considered analogous. In this subgroup, there were 94 senior level integrated residents and 219 fellows who responded to the survey. The rate of burnout in all of these trainees was 43.2%, and was similar between senior residents and fellows. The rate of thoughts of attrition was also similar between senior residents and traditional fellows. However, senior integrated residents did appear that they may have higher rates of thoughts of leaving the specialty of vascular surgery at 12.4% compared to 8.4% in traditional fellows, but this did not reach statistical significance. Overall, the trainee reported perceptions of the learning environment were generally positive, with high rates of job satisfaction, a sense of belonging, and operative or clinical autonomy. Traditional fellows did appear more likely to report satisfaction with the decision to become a surgeon, but this also did not reach statistical significance. In summary, we found that burnout was experienced by 44.6% of vascular surgery trainees, with significant associations with the experience of mistreatment and duty hour violations. Although both of these factors were reported more frequently by women, female trainees were not at risk for more burnout compared to their male counterparts. The rates of thoughts of attrition, specialty change, and suicide were all low, but we would caution that these may not represent accurately the experiences of women or persons from underrepresented minorities in vascular surgery. Finally, we found that senior level trainees have very positive perceptions of their learning environment, regardless of training paradigm. This initial analysis is, of course, limited by potential sources of bias introduced by non-response or the administration of the survey immediately following the V-site. Despite our high response rate, the overall size of the vascular cohort remains very small compared to general surgery or internal medicine, which limits our statistical power. This is particularly notable once again when considering the fewer than 5% of the training demographics who come from underrepresented minorities in vascular surgery, which may provide some additional impetus for future equitable recruitment strategies. From these results, we conclude that there is a need to improve wellness in vascular surgery training, but that the success of these interventions requires local expertise and understanding. The vascular surgery extension to the second trial is well underway at 42 vascular surgery programs to identify some of the best strategies to improve wellness, and we're excited to collaborate with the vast array of researchers, surgical educators, and professional societies to conduct this important work. Participating programs will receive reports on an annual basis similar to this, where they can compare their program's performance in various domains of wellness to other vascular programs in the country. Intervention arm programs also have access to our online wellness toolkit, where feedback from the program report can be tied directly to actionable steps to improve wellness. These interventions have drawn from the experience of surgical programs across the country, with many of these collected from pre-pandemic on-site study by our multidisciplinary second trial team. Through the work of the second trial, we aim to draw on the collective expertise of surgical educators to understand how to improve training in vascular surgery. I'd like to thank the ACS and ACGME for sponsoring this work, and also acknowledge the invaluable support of the Vascular Surgery Board and the APDVS. I'd also like to note the entire second trial team, including the co-PIs Yaron Hu and Carl Villamoria. And finally, I will note some of the key players on the Vascular Second Advisory Committee, which is still in the process of recruiting members at both the faculty and the trainee level. Dr. Don Coleman, who we've heard currently serving our country, but still playing an active role in spearheading this work. Dr. Mal Sheehan, who advocated tirelessly on our behalf to the board and all of the other key players. We've recently been joined as well by Dr. Guillermo Escobar and Dr. Palma Shaw, and myself, Debbie, and Eric are working to finalize the team for the ongoing work. You can reach the overall second trial by emailing second@northwestern.edu, and my contact info is listed here as well. And with that, I'll thank you for the time and opportunity to present here, and say please don't hesitate to reach out if we can help in any sort of way.
Matthew, thank you for that presentation. That was excellent. And sobering data. Our colleague Rabi Chair from UPMC says, scary and sobering data. Any way to get details on the high rates of mistreatment? Do we know what the mistreatment is, or and then how do we counteract that?
Absolutely. We've previously, in the work of the second trial in general surgery residents, been able to identify that some of the mistreatment is coming not from the faculty or from colleagues, but maybe coming from patients or administrators or nurses. And so some of this is really tied to personal level experiences of these individual items. And so making sure that each trainee is appropriately prepared and that they know, for example, ways of reporting, ways of having bystander training, and what specific mistreatment they might be more at risk for. And that's part of the motivation of the larger second trial, to be able to provide that data in a program level, more local format, while still maintaining some form of trainee confidentiality. I think that's the balance that we're looking to strike with the second trial. But I would say that mistreatment is not solely coming from their interactions with faculty or colleagues, but there's certainly a significant component from the other different team members who we interact with on a daily basis.
Thank you. It's definitely one of our roles as program directors, and this was addressed yesterday, but part of our, our evaluation process, there needs to be openness, there needs to be ways for trainees to be able to report negative interactions and have a way to speak up without retaliation. This comes up on the survey data every year. And I think we all think we do a good job, but just being available and having your door open isn't the same as having a anonymous way for reporting and a system that protects the anonymity and safety of our trainees. So everyone needs to think a little bit harder about how to do that better. Guillermo Escobar commented on the last slide, there were many negative comments on Twitter about adding the survey after the V-site. The trainees were tired, stressed, the test was already long. They said they didn't finish it, didn't do it. So this could be a little biased. Is there a place to do this that's a little less onerous on the trainees?
Yeah, we've definitely received these feedback from both the AB-site and the V-site administration this year. Some of the data that is actually under consideration for publication shows that the the distribution of emotions after the V-site is quite well distributed between elation and positive emotions after completing it and achieving that, as well as those who are more on the negative experience. I would say that this group is well familiar with the attempts to distribute surveys and other methods, even those that are coming directly from the APDVS, and suffering from relatively lower response rates because of that. And my counterpoint to some of my colleagues who have expressed this to me is that this is our opportunity to provide feedback in a unified and meaningful way to the stakeholders in surgical education, to the program leadership, in a way that is, I think, much more accessible and much more authentic to the voice that we have as trainees. So we've spent a lot of time to workshop the survey instrument every year to make sure that it is as short as possible. And for that reason, there are a number of different aspects to wellness that we are unable to explore in each year. But each year, the survey instrument is consistently modified and tweaked to address the things that the advisory committee feels is most relevant to the year. So for example, this year's survey incorporated some questions about response to the COVID pandemic and feeling supported in their safety and physical safety and personal safety with the response to the pandemic.
I think in the interest of time, we're going to end the questions there. We're scheduled. Thank you so much for that enlightening overview of the trial.